Okay. So let me first say that if my audio goes out, hopefully someone will be able to poke me. I've got my phone in the other room that I can transfer to. So if I have loss of primary, I can shift to auxiliary. The nuke part of me is still around. Um, and it is a dry topic. So um, um, that's the way it is. Okay, so we're ready here. So again, my name is Tim Breweiler. I go by pronouns he, him, and I'm here to talk about hard metal lung disease. Just over a year ago, if you asked me about hard metal lung disease, I would think it was the same as heavy metal. And I'm not talking about Iron Maiden, Megadeth, Motorhead, or Metallica, or Ozzy, or Black Sabbath. And I'm also not talking about arsenic, cadmium, chromium, lead, or mercury. Okay. Hard metal lung disease is something that's almost as hard as diamond. It's been around for about 1926, I believe, so almost 100 years. Okay, next slide, please. I was always recommended to put in a slide like this, and so you'll know we're getting towards the end if we get towards pulmonary symptoms, which is 2/3 of the way down on this screen. Next slide, please. Okay, so welcome. Again, we're going to talk about hard metal lung disease, a serious but rare occupational health concern. We'll start, most of what we're talking about is in industry, where the versatile metal cobalt is essential to the production of hard metals along with tungsten carbide. Numerous respiratory disorders ranging from more severe interstitial lung disease to occupational asthma and hypersensitivity pneumonitis have been related to cobalt exposure. The first documented cases of pulmonary complications in hard metal workers date back to the 1940s in Germany. Pathology known as giant cell interstitial pneumonia is unique among those linked to cobalt exposure. When GIP, or giant cell interstitial pneumonia, was first discovered in 1968, it was initially believed to be idiopathic or arising spontaneously. However, by the late 70s, the connection between GIP and hard metal exposure was evident. Next slide, please. Go back one. Thank you. Technological developments in machining, grinding, and drilling have been facilitated by cobalt's use in manufacturing, particularly in the production of hard metal matrices and as a binder in diamond tools. The cost of this advancement, meanwhile, is a high risk of interstitial lung disease for those who work on these processes. Interestingly, the risk is greatest early and in later phases of production when large amounts of small, say, 2 micrometer size particles of cobalt dust are released by machining and grinding methods. This raises concerns about the manufacture of bonded diamond tools and the coating of softer metals with hard metals with this same hard metal matrix, which increase the possibility of cobalt exposure in the workplace. Next slide, please. This one's for your reference, and it's if you look at the top half of the table, it's exposure known to cause cobalt-related interstitial lung disease, manufacturing, surface coating, tool maintenance, and sharpening. Okay, thank you. Next slide, please. This is just to give you some idea. I didn't know what sintering was. So it's interesting for making the hard metal. It's almost like baking a cake where you've got powders that you mix together. So tungsten, black carbon, and cobalt. A lot of times it's about 10% cobalt. You'll mix all of these powders up, and that's where it can be aerated and people could be breathing it. And then you'll compact it into forms, and that's the bottom third of the picture is the compacted forms that are then going to be going into the oven. And that oven's going to have a bath of, or I should say what's the word? All right, so it's going to be bathed in nitrogen and a little bit of hydrogen, and it's to keep the oxygen away from it. That's it for that slide. Thank you. Next slide. Thanks. So the current understanding of the pathogenesis of cobalt-related interstitial lung disease points to an immune-mediated response. This is still a complex puzzle. According to that theory, cobalt causes the body to mount an adaptive immune response, which in turn causes lung inflammation and fibrosis. This particularly occurs in the interstitium of the lungs, which is the support structure near the alveoli. In a hotel, the hotel room would be the alveoli, and the floors and walls of a hotel room would be the nerves, arteries, and veins, would be where the nerves, arteries, and veins are located. This mechanism is similar to chronic beryllium disease, being immune-mediated, in that there is no linear dose-response relationship in a variable disease onset. And if I was to say anything about this topic, and the frustrations with diagnosis, it is that piece, that this mechanism is similar to chronic beryllium disease, and that there's no linear dose relationship and variable disease onset, and that everybody's a little different and everybody reacts a little different, and how, shooting from the hip, like think about it right now, some people can eat shrimp or have shrimp steaming on one of those sizzling plates, and it goes right by you and it's not a big deal. Then other people have a reaction right away just from breathing in the smoke, right? Not even eating the shrimp. And it's really frustrating. It's really hard. It makes it harder to diagnose, right? Or understand who's going to have a problem. This theory is further supported by the existence of granulomas and cobalt's capacity to sensitize the immune system. It's interesting to note that genetic variables like HLA haplotypes are important in determining susceptibility, suggesting a complex interaction between exposure and personal predisposition. There have also been some observations and research showing that cobalt can cause damage from increased production of reactive oxygen species. So more reactive oxygen species, more damage. I have another blurb in here about HLA haplotypes if someone is totally interested in it, but basically it's T cell recognition, figuring out what is self and what's non-self. Next slide, please. History and exam, again, this is a good reference, just when you're trying to go through the occupational history for the patient. Hard metal lung disease necessitates hard metal lung disease diagnosis necessitates a thorough evaluation of work history. It's important to know whether a patient has been exposed to hard metal tools, bonded diamond tools, or metal coatings. Investigating metal cutting techniques and possible indirect cobalt exposures yields insightful information. If we're, I don't like the word lucky, but if we're lucky, maybe symptoms that start at work and dissipate when away from work may help you with a diagnosis of, say, something like hypersensitivity pneumonitis or occupational asthma, or some milder form of reaction to something like cobalt. I always have to, I wrote down in here that I always have to think about diamond polishers and dental technicians, because when I'm thinking about industry and cobalt, I'm not appreciating them as much. And I guess I should add in here prosthetics, folks that work on prosthetics. Next slide, please. All right, getting towards the end. Pulmonary and extrapulmonary symptoms, manifestations, excuse me. Cobalt-related interstitial lung disease can manifest clinically as acute, subacute, and chronic. And again, it can be somewhere on the spectrum. It's not like you go from one to the other. And from the folks that are out here listening, I think you guys know more about how these folks present than I do, because I'm just reading articles. But so it could be on the spectrum, acute, subacute, and chronic forms. So there could be dyspnea, coughing, and systemic symptoms. Could be examples of acute manifestations. Symptoms usually get better with removal from the exposure. On the other hand, chronic variants are going to come on more subtly, exhibiting symptoms that do not seem to be related to levels of exposure at the time. Patients frequently describe upper respiratory tract irritation, conjunctival symptoms, and allergic dermatitis in addition to lung irritation, underscoring the systemic nature of cobalt's effects on a person's health. Next slide. Workup. I was trying to focus this on primary care, on what options are out there, and it's kind of a challenge. I think uh, you guys you guys might have some of these options. Like, I don't think most primary care places would have spirometry, but if you're lung centered or if you're at Cabin, I want to call it Cabin John. I don't want to say it's because I'm from Maryland, but Cabin Creek, where you could do more of this work. So keep in mind to rule out connective tissue associated lung disease, such as rheumatoid arthritis, lupus, dermatomyositis, polymyositis, sarcoidosis. Cobalt skin patch testing is helpful, but it's helpful for occupational asthma and contact dermatitis from cobalt, not for hard metal lung disease. And I was reading about a cobalt lymphocyte proliferation test, but that doesn't seem to be helpful for hard metal lung disease either. It seems to be helpful only for occupational asthma and contact dermatitis. If we send them out to a specialist, bronchoalveolar lavage can be helpful, but not specific. It's frustrating. Patients can have high lymphocytes, high neutrophils, or high eosinophils. So it's not like one would hope that you could have high eosinophils. Okay, all right. Luan's like, yeah, I know why you said Kevin John. Thanks, brother. So, so I find it frustrating for bronchial alveolar lavage for, when you're trying to, what is a stereotypical patient, and you can't say, oh, one would hope, high eosinophils. Okay, I can hang my hat on that. No, it could be anywhere there. I'd love to hear your folks that are listening. I'd love to hear your opinion. I heard something about EPMA, electron probe microanalyzers, and that's going to be more for transbronchial lung biopsies. From what I was reading, it sounds like it's helpful if it's tungsten carbide, but not for cobalt, for picking up some of the hard metal in the tissues. Chest X-rays, I'd love to hear your experience, but they appear to be normal a lot of times. High-res CT seems to be the best way to look for hard metal in the lungs. Next slide, please. So I didn't talk about treatment because this is a crawl, walk, run phase, and it's just an initial piece to this. I was trying to focus more on hard metal lung disease and not occupational asthma and HP, but when I'm reading about it, they're kind of all together. But that's where we were trying to go, was hard metal lung disease today. So again, it's a serious but rare interstitial lung disease. It's used in hard metal matrices. Cobalt is used in hard metal matrices and as a binder in diamond tools. And it's not going anywhere. It's actually, it's going to be used more and more in electric vehicles on cobalt cathodes. And it seems to be that the risk is greatest with the smaller dust particles, such as 2 micrometer in size. Next slide, please. This is just as a reference. I just found this out of the Zhang article from 2020, which just seemed pretty helpful, breaking down some symptoms for occupational asthma, HP, and interstitial lung disease. Next slide, please. And this is just an, oh, by the way, IARC talks about the International Agency for Research on Cancer talks about carcinogenicity. Sorry, I had to concentrate. So, and it talks about cobalt metal. Cobalt 2 salts are a group 2A carcinogen. Oxide is group 2B, and weapons grade tungsten is group 2B. EPA, from what I could see, is not classified cobalt, and CDC hasn't classified tungsten. Next slide, please. But I have to put that in, so we said 2A and 2B, right? But okay, let's keep it in mind that processed meats, I don't know about you, I like bacon. Weekends, I like sausage, that's group 1. Red meat is group 2A. NutraSweet is group 2B. And night shift work, which we've all had experience at some point, I'm sure, is group 2A. All right, that's all I have today. And I appreciate your time. I appreciate you listening, and I look forward to your feedback. Thank you so much.
Thank you so very much, and thank you for the reference slides in there. I'm sure people will find that very helpful, Tim, so I appreciate that. Any comments or questions, and please, those that don't have a mic, feel free to chat it in.
Yes. So thank you, Tim, for doing that. That was great. And actually, so I'm a retired primary care physician. I worked for 40 years in a black lung clinic here at New River Health. And so for me, I'm really interested in this challenge that you were referring to, alluding to all the way through your great presentation on the interface between this kind of very technical and hard to find and hard to integrate information with primary care. And so, David, I've been thinking about you all the way through this. And so I'm wondering, so I'd really like to hear your comment about what to do about that interface between this kind of information and primary care, or any other thoughts you have, because it's challenging.
Trying to get my computer to work here. Well, I think the takeaway here is when you have a case of interstitial lung disease, or when you have a case of asthma or hypersensitivity pneumonitis on your hands, to ask about work, to ask about what the patient did, for a living, and if there is a suspicion that they had a job where that involved tests that put them at risk for one of those disease, to refer for appropriate evaluation. I don't think a primary care practice is going to do invasive testing, or see a lot of these, you know and you know so I think the big thing is to understand what would trigger you to refer.
Yeah, and so, well, I've got just sort of three things. One is, to me, the really big challenges for primary care 10 years ago now and 10 years from now are to, I mean, we're really struggling to get from all lung diseases COPD to about 40% of all lung disease is obstructive lung disease, and about 40 to 50% is interstitial lung disease. And then there's another 5 or 10%, we're not sure what it is, but there's a huge challenge for primary care to learn how to identify interstitial lung disease, which, unlike COPD, is about 100 things. And so just figuring out how to have that in mind is the big challenge for us. And then another big challenge 10 years ago now and 10 years from now, and this is even harder, is to think about work as potentially the cause of illness. We just don't do it enough. We're seeing colds all day long, skin rashes, and skin rash. Think about skin rashes and work, and yet it is not the paradigm that most of us are trained in even now. So just asking about work, it's almost more on the shoulders of the worker to consider whether his or her illness is being caused by his or her job. And generally, when she brings that to the primary care physician, she's met with skepticism, because we just don't think of it enough. And then the only other thing is that I loved your metaphor of the hotel for thinking about lung disease and trying to understand what interstitial lung disease is. That's what I came up with 20 years ago, and I think it's a good metaphor. And
Dr. Doyle, I stole it from you. You told me.
oh well, see. Okay, so I think it, until we find something better. So anyway, blah blah blah. So anyway, that's what I've got.
Okay.
And I know most of the other people here. So Tara Miller, Catherine Warner, Aaron Erb, all are respiratory therapists who are on the front lines, and they are in settings where they do think about occupational lung disease, but there's a pretty huge focus on mine-related dust disease. And so I'd be curious for the three of you, what you can do with this information and your providers that you work with. What's your sense of how awareness of occupational lung disease is actually getting a foothold in day-to-day primary care?
Two of them don't have a mic, but feel free to chat in. And then I think, Catherine, if you have any comments to what Dr. Doyle just asked.
Dan, I'll jump in really quickly and say that when surveys are done of medical records, it's rare for anybody to enter information about work, even in the social history. People rarely ask about work. And when there is information about work, it's usually, related to billing. It's not related to the medical information.
Yeah, yeah. Let's see. I know somebody's mic. See, Aaron can't talk, but yeah. But it's interesting the way all of us have transitioned to electronic health records in the last 10 years. So there's Aaron. I'll stop and take a look at what she said. Yeah.
Yeah, so I don't know if others didn't read that yet. She doesn't deal much with primary care. However, we do see ask when we do pulmonary function testing and in pulmonary rehab. But yes, she agrees with Dan. It's definitely not in the billing.
Yeah. So I think the challenge for us in the next 20 years, or for you, Tim, in the next 20 years, is to try to figure out how to give even just a simple question, like in primary care now, many places do a screening, a two question screening test for depression. It's called a PHQ-2, and it's become a routine part of medical records in the primary care setting. And we do vital signs, but there's no routine of asking what your work is, and the electronic health record is not required to force that. Everybody's got to give pronouns now, but we're not required to ask about work. And that, to me, is a major flaw in how the biomedical paradigm is working across the board and how the EHR is structured. And I don't know, not sure we can change that, but you can change it locally. Like we could work at Cabin Creek, Luann, to make it a routine part of things. I don't know how to change it systemically everywhere, but
So we've been working on that for some time at NOSH, and there's something called the U.S. Core Data for Interoperability, USCDI, which specifies what's supposed to be in electronic health records. And the last version of USCDI does recommend that at least current industry and current occupation of your current job be included in electronic health records, but that hasn't been implemented by vendors yet. The other issue is that current job, may not be associated with current disease. Your disease may be related to the usual job that you've had across your career. So for example, chronic diseases like cancer or COPD, may be related, to a job that you had in the past that you don't have anymore. So it's really key in taking an occupational history to look at the whole history and at least look at, what a person usually did across their lives in addition to what they're currently doing. And we have a system. There's something called occupational data for health, which is an approved structure for HL7 is the standard setting organization for electronic health records. And so we have a HL7 approved structure for including work information in electronic health records. But again, it hasn't been picked up and implemented much yet. And, we're working on it. Hopefully we'll get there. But it's a big blind spot in electronic health records right now.
But you are thinking about it and working on it systemically, which is great. And Luann and Catherine and Tara, a challenge for us in the Appalachian Pulmonary Health Project is to see if we can move on this locally at our sites, because we have direct connections to the primary care providers in our sites. Well, Aaron, it sounds like maybe you don't, but Catherine and Tara and Luann and I definitely do.
And we sort of feel that it's really critical to get the big vendors, like Epic and Cerner, to build modules, that would facilitate this. And if the information is recorded in a standard way, that can help to address your earlier question about what primary, practice can do. Because if you have standard information, then you can use AI and tools like that to prompt clinicians, to help them to ask the right questions.
Yeah, and to give the primary care provider in at the point of care something like there's a 20% chance that this rash is caused by current or previous work.
Yeah, I mean, you could see how you could, take something like the ICD code, plus the occupational codes and spit out that kind of information. Think about, this in your differential.
Exactly.
Thank you. And I saw Luann, you unmuted. Did you want to say something?
I did. I was going to say, Dr. Doyle, I know that part of what they were doing at the front, I don't work the front, but when we'd have our huddles, is they really were working the past several years on the depression screening initiative to make sure that patients were done every so often. It might even be a quality measure, I think, now with our EHR. And then in our department, when we do pulmonary rehab, it's done before they start the program, and then sometimes halfway through, but typically beginning and end, to kind of gauge how the programs help them with that. And I think they're also working on something now as time goes on with our coal miners as well. So really trying to capture that, because that does affect a lot of other areas of their health.
And Luann, do you see Aaron's comment?
Yes.
So Tim, Dr. Weissman, I wanted to make a segue to another question, which has to do with turnout and participation for this, but I don't want to do that until we're sure that we've finished this topic. And again, thank you, Tim, for doing this.
What I would ask is if Dr. Weissman and Dr. Doyle, if you guys could even one line to Robin Altabello, I can't speak today, Robin Altabello and Dr. Chris Martin, just to say, hey, he was cogent, he was on time, some basics. I'd appreciate it.
Put their emails in the chat.
Say again?
Put their emails in the chat.
You got it.
And I know Chris Martin, I don't think, but anyway, I'll do that. So is it okay to, so anyway, Elizabeth, I'm concerned that the turnout was limited here because of, we haven't fully completed the transition to iEcho. And I'm sure you guys are thinking about that too. What can you tell us? And is there anything we can do to help? I'm worried that people, haven't kind of got through all the hoops, that there would have been other people here except for that. Is that your sense?